This is Angry Bill for Pre-Hospital Wisdom. Pre-hospital wisdom here is where we understand that medicine's medicine, but pre-hospital providers, EMTs and paramedics, have a specific skill set and culture and knowledge base that makes us different from other medical providers. So I want to talk to you about mnemonics, at least a little bit. I hate mnemonics, and it's goofy that I do because I use them all the time. To me, mnemonics are like something you give to dumb people to help them remember easy stuff. And I don't need like little rhymes or things like that to remember my job. But then I go and find myself using mnemonics all the time. I use AEIOU tips all the time, the 7 S's of single sedan smashes. There's a whole bunch of mnemonics that I end up using. There's a whole bunch of mnemonics for difficult airway prediction tools. So, for example, difficult bag valve ventilation can be identified using the MOANS mnemonic. What we're looking for is mask seal, obesity or airway obstruction, age, especially over 55, no teeth makes it hard to bag people, and either sleep apnea or stiff lungs. It's kind of a goofy one to me. Stiff lungs is fine if someone has ARDS or COPD or something that makes some sense. But just because they have sleep apnea doesn't help me a whole lot. Unfortunately, MOANS is not one that I use very often. The reason for that is because they're going to be a difficult patient to bag means that not a whole lot to me. When I need to bag them, I need to bag them. It doesn't matter if they're going to be difficult or not. It's the same thing with the difficult extraglottic device, RODS, is that mnemonic. Restricted mouth opening, obstruction, again with the airway, disrupted or distorted airway, stiff lung or cervical spine. That's RODS for you. And again, if someone needs a eye gel or something like that placed, it's kind of what needs to happen. The one for difficult crike, our difficult front of the neck airway, is SHORT. That stands for past surgery or airway obstruction. A hematoma can often end up distorting the airway, plus making it a whole lot thicker and harder for you to dig down through. Obesity, it's kind of the same problem. Radiation distortion, and then tumor in that area can make finding the anatomy and performing a surgical cricothyrotomy a difficult process. At my agency, as part of our RSI checklist, when we're going to RSI someone, I don't have to sit there and remember the mnemonic for the 7 P's of RSI. What we actually do is we have a checklist that we read off, a lot like a pilot would in an emergency or something. I find it's extremely helpful. One small problem that I have with it is that it uses the difficult intubation mnemonic, difficult laryngoscopy mnemonic, LEMON. And LEMON to me is actually fine in theory. So let's explain it. It starts with L, look. Look externally. Use your clinical judgment. Is this going to be a difficult airway or not? E is evaluate. We're going to evaluate the 3-3-2 rule. So what we're using is 3 of the patient's fingers into their mouth, 3 of the patient's fingers from the point of the mandible back, and then 2 from the top of the jaw right there to the thyroid cartilage. That's a 3-3-2 rule. Take a look inside their mouth and assign a Mallampati score from 0 to 4. Obstruction or obesity, meaning if there's something in the neck or in the airway that's going to make it difficult. Same thing with obesity. That can start to be managed with a whole bunch of ramping like here. And then finally, neck mobility, either due to arthritis or ankylosing spondylitis, but even especially due to trauma, cervical collar placement, that kind of thing. So that's LEMON. Part of the problem that I have is it seems to me that this is developed for more elective airway. Like if grandma's going to get a new hip and we're trying to decide, am I going to put a laryngoscope in her mouth, or am I going to am I going to use an LMA or those kinds of things? That's kind of what that's more there for, the 3 fingers in the mouth concept and stuff like that. Yes, Knowing that that's going to be a difficult airway is one thing, but a lot of my airways are absolutely not elective. And knowing that it's going to be difficult doesn't make it any less difficult. The mnemonic that I actually end up preferring is Heaven. Heaven came from the Air Methods group and was published in 2019. It is predicting difficulties with emergent intubation, not just difficult intubation, but peri-intubation arrest, desaturations, all those things, all the problems that we worry about when we're intubating someone. The mnemonic for this is Heaven, stands for hypoxemia. Oxygen saturation value less than 93% is going to present problems. Extremes of size, whether it's pediatric or clinical obesity. Anatomic challenges like trauma, masses, foreign bodies, structural abnormalities can make the airway placement a lot more difficult, of course. V stands for vomit, blood, fluid. Anything that requires suctioning in the airway is going to make it a more difficult process to pass a tube. E is exsanguination. Suspected anemia can accelerate desaturation. And then neck, limited cervical range of motion, also makes it more difficult to place the airway. So this to me is a good reminder to maintain the patient's blood pressure, maintain the patient's oxygen saturation, pre-oxygenate, all of those things that we're doing with an RSI. To me, this is a much more specific tool usable in the pre-hospital setting than putting 3 fingers in someone's mouth. That's why I prefer the Heaven mnemonic, no matter what's on my checklist at my agency. So what do you think? Do you use a clinical judgment, or do you use a specific tool like this? Let me know down in the comments below. Make sure and subscribe and share. That really helps to get the word out. Once again, this is Angry Bill for Pre-Hospital Wisdom. Stay safe until next time.